So we have the one, the only Amy Graham from Graham Speech Therapy back. Amy, thank you so much for coming today.
I'm so happy to be here. Thanks for asking me back.
So, if you have not heard Amy's other episode, it was one of our top 10 episodes of all time. And we are celebrating our 10th anniversary of the Speechy Side Up podcast and our 5th anniversary for the Tassel Learning Network, which is the network that provides ASHA CEUs for Speechy Side Up. So, we asked Amy to come back on and tackle a very important topic that has been circulating around social media and Facebook groups recently. So we wanted to hear Amy's perspective on this topic, and it's called Beyond Form and Function, Making Sense of OMDs and SSDs. And just to clarify, OMDs is orofacial myofunctional disorders, and SSDs would be your speech sound disorders. All right, so let's talk about our learning outcomes for today. Since this is approved for ASHA CEUs, we hope by the end of this pod course that you'll be able to describe what the research says about OMD therapy and how it could or could not help speech, be able to describe what the evidence says about whether OMDs cause SSDs, identify signs that show when a child may have both OMD and SSD, and then finally, describe at least 2 evidence-based approaches to actually treating speech sound disorders. Here's our agenda for today. We're going to do a brief introduction and backgrounds, which we've already started to dive into. And then we'll talk about the overlap of OMDs and SSDs that we might see. And then we'll talk about whether they cause SSDs. And then we'll get into whether OMD therapy can correct speech sound disorders. Then we'll talk about evidence-based practice for treating speech sound disorders. And finally, we'll wrap up with our closing remarks and resources. All right, Amy, if someone has been living under a rock in the field of speech language pathology and has not seen you present yet, or maybe is just getting into this area of articulation and phonology, can you share a little bit about yourself?
Yes. So I've been an SLP for over 25 years. I'm originally from Southern California. So I went to school in Orange County, Cal State Fullerton, go Titans. I did my undergrad and my grad out there. And I was one of those people who kind of got into speech sound disorders. Or really, I got into the field because I thought that's all we did. And I thought that sounded really fun, helping kids correct their R's and S's. And so little did I know getting into the program, how gigantic our scope of practice is. And so I went into lots of different avenues and areas of practice, worked in the schools a lot of years, but kind of rediscovered my love for speech sound disorders in the schools because I found that if you matched the intervention to the underlying deficit, I could see improvement in like real time in the moment. And you don't always get that with a lot of things that we treat. You're like, am I doing any good? Is, this language aspect that I'm working on, is it really improving this child's ability to communicate? With speech sound disorders, you're like, yes, that kid can say that sound now. And I help them do that. So I started specializing in speech sound disorders back in 2016. We're in Colorado now. And so since 2016, I've had this little private practice here in Colorado Springs, and I have a really small caseload where I still see kids starting, beginning at 3, anywhere to like teenagehood. Always have a teenager on my caseload, it seems like, working on a particular sound. I still have a small caseload, but primarily now what I do is a lot of resource development, product development for speech sound disorders, assessment and intervention resources. But I do a lot of professional development now. So I have live webinars I have on my website, grahamspeechtherapy.com. I have a lot of recorded courses. I travel all over. In fact, I'm leaving for Canada next week. So I do a lot of professional development, and that's what I do. That's primarily my job now.
Amazing. And you just came back from Australia or New Zealand, right?
Well, both. Yeah, I was invited to present all over in 4 different cities all around the country in Australia over the summer. So I just got back from there. And then we took a little, side jaunt to New Zealand, because if you're in that part of the hemisphere, how do you not? So
Right.
we had some fun, really a blast. My husband and I just seeing Australia and New Zealand, and I would love to go back sometime.
That's amazing. It's so great that you were able to take him along with you. I'm sure he loved that.
Yeah, great experience for sure.
Well, maybe you're here for Amy and you are not familiar with me. Maybe you're watching on YouTube or the podcast for the first time. My name is Vanita Litvak, go by she, her. I have been an SLP since 2014. I'm the host of the Speechy Setup podcast, and I am the CE consultant for Tassel. I also have a very small private practice, but specializing in early intervention in AAC. I recently started becoming an adjunct professor at UCF, and then this fall I'm at FAU teaching AAC at the graduate level, and then I also started a SLPD program at Northwestern this summer. Really quickly, I have ownership interest in Speechy Side Up LLC and Tassel Learning LLC. And then Amy, do you want to share your disclosures as well?
Yeah, I'm the owner of Graham Speech Therapy. So that's how I make my living, is for my resources and courses that I sell there. But I receive royalties from Bureau of Speech Publications because I've authored a lot of decks for them. It's card decks. And I have an affiliate relationship with MedBridge, Super Duper, Easy Peasy, and SLP Toolkit.
Awesome. All right. So I'm very excited to hear your thoughts on this. I know that you have been in this area of articulation and phonology for quite a while now. So do you see any overlap in kids who have both orofacial myofunctional disorders and speech sound disorders?
Such a great question, because I feel like we have to kind of define our terms, right? Like, what are we really talking about when we say speech sound disorders? And so when I do any of my courses, I like to delineate what do we really mean by speech sound disorders, because there are subtypes. And so we have our motor speech disorders like dysarthria, apraxia. We have our phonological based speech impairments where it's rules based, understanding the rules for when we use sounds, how we use sounds to change meaning of language. It's more of a linguistic underlying deficit there for those kids. And then we have our motor articulation based speech errors. And I will say, I should say this right off the bat, I am not a researcher. I am not an orofacial myologist, but what I am is somebody who specializes in treating and assessing children with speech sound disorders. So I want to do my best to know, okay, what is the best evidence out there for how we assess, how we diagnose, how we treat kids with SSDs? And then I also want to keep up to date on newer strategies and what types of interventions are out there, what's kind of coming down the pike. And so what I have tended to see, and I will say I've taken courses on orofacial myology. I am not certified in orofacial myology, but that is kind of a sub area where SLPs do specialize in that particular aspect. And so when we're talking about orofacial myology from somebody who doesn't specialize in it, so hopefully I'm doing justice as to describing what it is really a deficit in the way or the function of how kids, even adults, are potentially using their muscles of their face, of their mouth, of their articulators, not just during speech, but during, at rest, during a swallow, breathing, and where those articulators are and how they could potentially impact aspects of that person's life. So for example, we're familiar with the term tongue thrust, right? That's a swallow pattern where that tongue juts either against or through the front teeth when you swallow. So if we swallow, typically, as I'm swallowing right now, your tongue moves up and back to kind of move that bolus down where it needs to go as you make that swallow. But if you have a tongue thrust, the tongue actually moves forward, which is a very typical swallow pattern for infants and toddlers. But a lot of us tend to grow out of it, not all, but we tend to kind of grow out of that as we, age and mature. But that is a sign, if that persists, that, okay, your tongue is not moving in a way that might be the most efficient way to move for an adequate swallow. Or if you have your tongue like low at rest in your mouth. If you think about it, whoever's watching this, as you're sitting here breathing, likely through your nose, if you think about that, or if you're breathing through your mouth, think about how you're breathing. If your tongue is low at rest in your mouth and not naturally resting up in the palate, which is kind of what we are going for, that typical rest pattern, you might notice some differences in structure of the mouth, of the palate, and so are the dentition, malocclusions potentially. So there's some signs that we can see of orofacial myofunctional impairments when we look at structure and when we look at function. So anyway, just kind of a brief little overview of what I'm looking for among my kids who have speech sound disorders, because what I tend to notice, and this is just in practice, what I have tended to notice is my kids who have residual speech sound articulation errors. I tend to see kind of an overlap there with my kids. So I don't tend to see OMDs being a huge issue impacting the linguistic phonological based speech sound disorders, because that's not the deficit. The deficit is not motoric, like, am I able to get my articulators in the right spot? The deficit there is, do you understand how to make the sound? Like, we're still having to teach them how to make the sound, but do you know the rules? for when we use those particular sounds. So I don't tend to see OMDs have a big impact on intervention with my kids who have linguistic phonological based deficits, and with my kids, like, for example, and we're only talking really articulation and phonology today, like motor speech is a whole other area here, but like kids with apraxia, the deficit there is motor planning, right? Like the message is getting jumbled from the brain to the articulators. So that doesn't necessarily in and of itself mean that tend to see OMDs have a big impact on those kids as well too, unless they're co-occurring, which can always happen, right? But if we're talking like causation, which, we can get into that a little bit later. What I'm talking about is correlation, which is we're talking here overlap. So I tend to see more of an impact with my kids who have that subtype of speech sound disorder where they're struggling with that particular sound that they're struggling with. And if you think of those kids who are like 7, 8, 10, 14, like you think of those kids who are still on your caseload as an SLP, who have a particular sound that they're still working on. That's where I tend to see those kids who have also, in addition to the articulation error, an underlying, or at least signs of an underlying orofacial myofunctional disorder. Like, okay, that kid with that R distortion. I'm not talking about the 4-year-old who's gliding the R sound, right? They say wed for red. That's a language-based speech sound disorder that we can address with, minimal pairs or the complexity approach or a phonological type of intervention. I'm talking about a 10-year-old who wed lead for red. So if you're an SLP, you know the difference because you know how those kids just present differently. And so that child, if you think about that particular R kid, for example, what are they doing with their tongue when they say that R sound? Lead. Like if you do it to yourself and you think, okay, here's my R, red, lead. Where's their tongue? It's low in their mouth, right? And so if I see a child who's doing that, I want to pay careful attention to, okay, is their tongue not only in the wrong spot for this sound that they're struggling with, but is it in the wrong spot always, right? Where is it when they're breathing? Where is it when they're swallowing? So I tend to see overlap, kind of a really long introduction, but I tend to see overlap with those types of cases, and much more so than any other type of speech sound disorder.
Okay, thank you for sharing that. Do you see a particular type of OMD when that happens? Like, is there one that is more common when you see that in an older client?
That is a great question, probably for an orofacial myologist who'd be able to delineate the different types. But I would say what I tend to see when I see my kids who are struggling, or even my adults who are struggling with speech sound disorders, what I tend to see are things like, well, before we get into that, what I should say is if you are an SLP and you're suspecting you have a child, a teenager, an adult who has a residual speech sound error that they're really struggling with, make sure you do a thorough case history. Make sure you do a really thorough oral mech exam, an orofacial exam, because that's how we really uncover some of these red flags for those potential underlying functional impairments. So, like, for example, what I tend to see when I do my oral mech exam with my kids who have these underlying issues is I will see a high, narrow, or vaulted palate. So if you look at that hard palate, and if it tends to be, once you look at enough palates in your life, you'll notice the ones that are high and narrow. And when you start to see that, to me, what I'm wondering is, okay, if the palate is high and narrow, that may likely be because the tongue is always low at rest in the mouth, not resting in the palate, acting as that natural palate expander over time. Now, there could be any number of reasons for that. Maybe the child has, an upper airway issues, right? Maybe they have enlarged adenoids or enlarged tonsils, so they struggle to breathe nasally. And so if they're not breathing efficiently through their nose, where else do you have to breathe but through your mouth? So if you're breathing through your mouth, your tongue has to be low in your mouth so that you can actually breathe efficiently. And so when I see those types of things, it doesn't always tell us why that's happening, this is something when I see like a high narrow palate and I'm seeing that maybe that jaw is even lax at rest. Like I've seen kids who breathe through their nose even, but their jaw is kind of lax. Even if their lips are closed, their jaw is lax. And if your jaw is lax, that tongue is probably low in your mouth as well too. So there could be any number of reasons that could be happening. It could be upper airway issues. It could be noxious habits. It could, I have kids who have differences in structure because of prolonged thumb sucking or pacifier use. And some obvious structural differences may be an open bite, may be crowding of teeth because of that narrow palate. And so when I see some of those types of things kind of pop up, that makes me wonder, like, okay, there could potentially be not just the speech error going on, but some underlying functional issues with how the tongue is or isn't moving efficiently, not just during speech, but for other issues too, like, swallowing and things like that. So anyway, I don't know if that answers your question. I didn't get rambling on this topic a lot, but that's what I'm noticing. That's what I'm looking for. I'm asking in the case history, do you snore at night? Does your child snore at night? Do they have trouble clearing their oral cavity during feeding? Like, do they struggle with just how their tongue moves during feeding? Are they messy eaters? Do they have food sensitivity or texture issues? All of those things can kind of help us uncover that, okay, maybe there is something functional going on.
Yeah, that makes sense. And that does answer my question. So thank you. I think it really points to doing a case history and a thorough oral mech exam, which you do have on your website. I think I've purchased it before, right? Is it still there?
I do. It's still there. Yeah, I have I made it really honestly for myself. I wanted a case history that was specific to speech sound disorders. It was going to ask all the questions I wanted to know to help me with my differential diagnoses, and an oral mech exam as well too. It's one of the first things I created for myself because I wanted something that was really thorough, but that was really easy to give and just kind of checklist style. So yes, I do offer those on my website.
Yeah, it is very easy. I'll say that for sure. Any idea like how often these are co-occurring? Is there any research that has like statistics on that? I'm curious. I might have to look that up if you
Yeah,
know.
you should probably look that because I don't know off the top of my head. I know there's more and more research coming out, and I try to keep up as best that I can. I try to, since like I said, I'm not a researcher and I'm an SLP who just, tries my best to keep up. I try to stay abreast if I can, but I'm not aware specifically of like overlap. Yeah, that would be a great question. I would love, it may be out there. I'm just not particularly aware of the specifics of it.
Yeah, I'm gonna take a look at that. It does seem like the research is like slightly lacking in this too. It's like there's like two parallel
They're
like
two parallel worlds.
yeah, exactly. And I feel like other disciplines have like adopted the OMT and OMD arena,
Right.
whereas it's under our scope of practice as well. So I feel like that's also problematic.
Well, then that's tricky too, because there's our scope of practice, which is ridiculously insanely huge. But there's also this thing that we have to consider our scope of competence, right? Like there are certain things that are outside of my scope of competence. I don't ask me to do any feeding therapy. I am not prepared to do that. I do not have experience. Don't ask me to do AAC, right? Like that is not my area. I'm going to refer somebody to you for that. So I think, yeah, we have to kind of consider that as well too. And I think that's challenging because I know in the OMD world, there are also, unless this has changed, not only are SLPs trained in it and can be certified in it, but so can, oh gosh, what is the other? Yeah, like dental hygienists can do that too. So I think we have to be really careful because, a dental hygienist does not have any knowledge of speech, right? And so sometimes like claims being made by other professions regarding, like I've heard false claims being made, like this can do this for you. I'm like, oh no, I have never seen any evidence for that. So I think we have to be really careful where we get our information from as well too.
Yeah. And I think sometimes even those fields are regurgitating information that they're not looking into deeper, like maybe an old research article or something.
I know, it's so true. Like we have to be very diligent in where we're really getting our information from. And I think, in the age of social media, things can kind of spread that are just inaccurate, but that are really catchy. So we have to be really careful to look at the evidence.
Yeah, exactly. That's why we're talking about this topic. So let's get into this part. Do OMDs cause speech sound disorders?
This is such a great question. And I'll be honest, I have never seen any evidence for a causal relationship, even though I do see correlation and co-occurring OMDs, especially like I said, with articulation types of errors. But think to yourself, how many people out there are, and granted, I have had a show of hands all the time, like, where's your tongue in your mouth right now? Is it low? Do you have a high narrow palate? Like I've seen adults with obvious, signs of an orofacial myofunctional impairment, and it may impact other areas of their life, but their speech is beautiful, right? Like they can really compensate well for, how their tongue does or doesn't, function during particular movements that may or may not be related to speech. So I have seen no evidence of a causal relationship. In addition to, and I know, we're not talking about tongue ties necessarily today, but it does have some relevance here. The same is true for tongue tie. There was just a recent article out, since 2020, honestly, that again looked at, is there a causal relationship between the tongue tie and speech sound disorders? And the evidence is really no, because in the vast majority of cases, most people, even with a tongue tie, have the ability to compensate for those restrictions pretty well. However, I will say this, we have to take those at a case by case basis, because I have had some kids with speech sound disorders and what I would consider a tongue tie, that restricted lingual frenulum that's kind of anchoring the tongue, to the jaw. And it seems like for some of those kids that, it really does impede their ability to, they struggle with compensation, right, for that. So I think we also have to take that with a grain of salt and really look individually case by case with our kids too. But as far as a causal relationship, I haven't seen the evidence for that. If it's out there, somebody send it to me. I just haven't seen it.
Thank you for sharing that. And I think I wanted to pull in some of the research from Dr. Kelly Farquharson. She was recently on the podcast too. She came back for their anniversary series. And what she said really fascinated me. And I wanted to hear your thoughts on this too, is that she doesn't believe that something is just an articulation disorder, that it's usually encompasses phonological as well. What are your thoughts on that?
I do, it's a fascinating theoretical conversation, because I tend to agree. Like I've even heard, I've seen other literature coming out that's saying there's no such thing as a phonological disorder because it's a motor issue. That's why we see these phonological impairments. And I think from a researcher theoretical standpoint, I totally would agree with that. Because really, even with phonological based speech sound disorders, like if you think of your fronter, it's like those kids who are fronting and they can't say the K and the G sound, they're struggling using the front of their tongue. Well, is it an articulation motor based error? Is that the issue going on, or is it phonological? And my answer to that is it could be both, because, speech, even if you see like a child who is having these really obvious error patterns of omission and substitution, speech is still a motor task. Right? Like you still have to work on the motor production. You still have to teach the child the rules. So in my perspective, I'm just a clinician, right? I am just trying to look at the child and look at what they have trouble with. And I'm trying to find an intervention that's going to help address that the best. So like, for example, we tend to think of, oh, well, if a child is just struggling with this one sound, then or if they're not stimulable, it's pure motor based, it's articulation. But what I'm going to ask myself is, like, let's take a child who can't say the TH sound and they use maybe F instead of TH, right? So it's this obvious sound substitution. Well, is it because they're not stimulable for TH? So is it purely motor? So I'm just going to teach them how to drill, TH words, teach them how to produce that sound. Yeah, potentially that's part of the issue. Like it's a motor task. We have to teach them a new motor task. But what's going to most effectively teach them the difference between an F and a TH when you have a word, right? Like teeth and teeth. Like maybe you might consider a minimal pairs approach, because it is more phonological, because we also have to teach the rules. So in my opinion, like I would agree with Dr. Farquharson. I haven't listened to that episode, but I would say, I've talked to Kelly before, like it's kind of this that's almost like this spectrum of, you can have two kids who are fronting, but one is going to be more motor impaired, and one of them is going to be more phonologically impaired based on maybe how stimulable they are. So yeah, I think we have to kind of take all aspects in and be a little more nuanced in how we treat those kids. Some kids we're going to have to spend maybe more time on the elicitation phase of therapy and teach them the actual motor production and precise articulatory contact for particular sounds. But then, okay, which intervention, once you've done that, which intervention should you choose? Is it going to be more of a motor-based articulation intervention, or should it be more of a phonological intervention? So there's like, we could talk about tons of case studies where my answer might be different depending on how the child presents, even if these two kids have the same types of errors.
That makes sense. I like how you describe it as a sliding scale. I mean, it just really points to the fact that we're working with humans, right? And
Right.
it's not black and white. They don't
Exactly.
fit this mold. But I think it's important to talk about that because if it's not just like the structure that's causing, a sound error, it's more phonologically based and motor based, then that even points to more reasoning as to why OMDs don't cause speech sound disorders, right?
So I'll give you an example. So I had a kid who I did an oral mech exam. He had like, for example, he had a high narrow palate, he had a tongue tie. He had, it's like, oh, okay, there's some definite, obvious orofacial myofunctional impairments going on here. However, his only speech issue was stopping of fricatives. And so I had to think to myself, okay, is this difference in structure and function that I'm seeing causing this particular speech error? My thought process for that was no, absolutely not, because there's no physical movement that child couldn't do that difference in structure or function would prohibit him from doing. And, I will say we did some therapy where we're like eliciting the sound, helping them produce the sound. He could get it pretty easily. And we used a phonological intervention for that child. And within 6 months, he was in and out of therapy. And I've had kids like that too, where we have to for example, I had another a glider where it was kid couldn't get the L sound. And so he had been in therapy elsewhere for orofacial myofunctional therapy. And so what they were working on was elevating the tongue tip, because the therapist thought, well, he can't elevate his tongue because, this L, he can't get his tongue up. And so they'd worked on it for 6 months and the kid still was not improving. They came to me. I can't remember how they found me, but they're like, we need to try something different. This isn't working. In one session, I got him to say the L sound and the W sound and practice those with contrastive, production. So like using minimal pairs. And in like 2 months, he was in and out of therapy. Because again, yes, did that child have an underlying myofunctional impairment? Yeah, for sure. But that was not the issue for that particular child. So we have to think very carefully about structure and function. Even if there is underlying myofunctional impairment, that doesn't mean that, we cannot choose a very speech specific intervention and should, as we're going to discuss in a little bit, to remediate their speech sound error.
Those are such great examples. And, before we got on the call, I was telling Amy that my daughter sucked her thumb. She had the high narrow palate. She had the teeth crowding. She is almost 5 now and can say every single speech sound. So there was no causation there. There was the OMD and then there was the, perfect speech. But we've stopped thumb sucking and actually the teeth have completely gone back to the way they are without really any intervention at all.
It's amazing. Yeah. In fact, I have a similar story. One of my kids sucked, I won't say him or her, so nobody knows who it is, but sucked their thumb for a little bit too long and had an open bite. And so what happened, I'm thinking, oh man, high narrow palate, open bite, noxious habit causing difference in structure. We eliminated the habit and within 2 months, that open bite was gone. So it's like those bones are so soft, right? Like different habits can absolutely, impact the structure of the mouth. So, but again, no speech errors. He had no speech errors. So was it did I see the causal relationship? Absolutely not. But will there be some kids who struggle with particular sounds? Like what I tend to see is my lispers, lateral, frontal lispers, like residual R errors, those R distortions, those tend to be my kids where I see this other issue with, man, they're really struggling to get their tongue in the right spot. I think their tongue's in the wrong spot for other things, right? At rest and swallow. And so those are the kids where I'm like, well, maybe that also needs to be remediated along with their speech errors. But those are two distinctly different types of deficits and treatments to remediate both. And I think sometimes orofacial myofunctional therapists or orofacial myologists hear me say there's no causal relationship and hear that I'm saying then, OMDs don't exist. Absolutely not. They absolutely exist. I see them, I see adults with, once you know what to look for, different jaw structure, even because it can impair or affect how the facial bones grow, even based on, what you're doing with your tongue and your jaw and breathing and all that. So they absolutely do exist and they can have tremendous impact on breathing, on eating, on, I've even heard other things are outside of my scope potentially. Yeah. All I'm saying is that they don't necessarily have an impact on speech.
Makes sense. Point blank. Evidence to say that they do either.
Right.
And we are going to show a systematic review at the end that you can look into further. It is open access, so you can, it reiterates much of what Amy is saying today. All right, so let's talk about whether OMD therapy can correct SSDs. I think I have a hint on where this is going.
Yeah. And I think that the article that you referenced, I encourage everybody to read it. What it really shows is that, first of all, the effectiveness of orofacial myofunctional therapy for speech sound disorders, specifically for speech sound disorders, just really isn't there when you look at the high quality, those high quality, journal articles and those studies that have been done. So I think it's important to understand that that's pretty much what I've kind of always assumed to be the case. And this is kind of showing that same thing. There's no conclusive evidence that orofacial myofunctional therapy as a standalone treatment improves speech among kids with speech sound disorders. So I think there's some part of it where it's like where it's combined, like let's treat the underlying orofacial myofunctional impairment. Let's also treat the speech sound disorder. There's not even strong evidence that adds benefit. We're talking speech though, right? Like I'm not talking about, does it improve swallowing? Does it improve, breathing? Does it improve, tongue placement at rest? I'm talking about specific to speech. So in those higher quality studies, even when it's combined, there's no evidence that I have seen, or even I don't believe that this article even shows that that articulation is improved beyond just using a really appropriate intervention for that child's speech sound disorder that is speech specific. So I think, yeah, just read that article. I think it's a really, really valuable insight, and hopefully there'll be more studies to come, to kind of dig into that even deeper.
Yeah, absolutely. They definitely said there's the need for more research. And why is this important? I think it's really important to hear what Amy's saying and like what that article is saying, because when you are treating speech sound disorders, you're dedicating resources, you are dedicating time. And if you are using it on a method, maybe you're combining OMD therapy and phonological therapy, where if the research is not showing that the OMD therapy is beneficial with or without, like standalone or paired with the phonological therapy, then you're wasting resources and time on that client, right? Because you don't have the evidence to support that.
Absolutely. And I think also another point that we should talk about is some of the terminology is very hazy. And some people think, especially like even when they see the acronym OMT, some people interpret that as oral motor therapy, right? And oral motor even has different connotations. So if you're talking, it depends. And there's oral placement therapy, and there's all these different definitions. And sometimes people define them a little bit differently. And so it's really important to understand that in general, regardless of what terminology and what acronyms you're using, if you are trying to focus on a non-speech movement for the purposes of, let's say, what I see with my kids, for example, who have like residual R distortions, is they have a difficulty dissociating their tongue from their jaw to move that tongue really efficiently and effectively independently. So if you think about the R sound, you have like 4 tongue movements you have to do, right? You have to elevate the front, you have to pull it back, you have to elevate the sides, you have to lower the midline, like all those things you have to do. And if you struggle with moving your tongue independently, that's going to be a challenging sound to produce. However, so when I do my articulate or my oral neck exam, I ask my kids, stick your tongue out, move it side to side. I want to see, do I see a still jaw? And if you can see me, I'm not moving my jaw, I'm just moving my tongue. What I often see with my kids is this. Their jaw's kind of moving along with their tongue, or maybe they have poor proprioception, so they're moving their tongue along their lips to feel that, tactile input. But when I see that with my kids, that doesn't mean to improve the R sound, I have to teach them how to wag their tongue independently, because that is not related to the speech task. So if we want speech to improve, we have to be very task specific in our intervention. So if I want R to improve, I have to work on the specific movements necessary to make the R sound. So I think that's important to understand too, because if I just have my child, do a non-speech task, like, okay, see if you can elevate your tongue tip up and down, up, down, up, down, up, down. And you're not doing it in the context of speech production, there's no evidence that that is going to automatically improve speech or carry over to speech production. So for example, like if I have my kids who struggle with tongue tip, or getting like their tongue in the right spot, I would do it with the speech task. So like, okay, open your mouth. Let's see if we can say the L sound by keeping your jaw steady and say la, 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 la to kind of get that tongue jaw dissociation. That is what I've seen improve tongue jaw dissociation. Work on a speech task to improve it. So there's a variety of ways to do that. I have an R course where I can go into specific tasks that I found have helped with that. But I think too, like if you're working on, okay, we're going to do some oral exercises or oral tasks. I don't even like to use the non-speech oral motor exercises because I know OMT or OM therapists don't like that term because they think it conflates too many things, which I understand. But I would say, regardless of what you call it, if you're doing a non-speech task and like, let's pucker our lips to get our lips really strong, tell me what speech sound that is going to improve. I can't think of one because honestly, you don't need a lot, even for bilabials, PB and M, you don't need a great deal of strength to produce those sounds. It's about learning how to produce that sound and getting lots of practice producing that sound to build up new motor pathways in order to create the skill to produce that sound. So I think we have to be really, really careful about why, if you're doing kind of an orofacial myofunctional centric type of intervention to improve speech, we need to be working on speech tasks.
I love that. I think that was such a good example. And I just want to reiterate what you said. When you're doing an oral facial myofunctional examination, just because they couldn't perform one of those tasks, it doesn't mean that you go and make a goal for that then.
100%. I think that's one of the biggest misconceptions about it. Like, oh, well, they can't do this particular task. They can't elevate their tongue tip, but they're gliding, right? That's a phonological based error. So you can teach that L sound in a different way if a 4-year-old has trouble, raising their tongue, because that's just a challenging motor task to explain to a 4-year-old. You can have them, bite it gently between their teeth to say the L sound. Oh, so that you can start to create a difference between W, lips, ooh, one versus, walk, lock, right? Just trying to create that distinct difference for a phonological impairment versus like, is it a motor task? Yes, it's a motor task, but that doesn't mean that we have to treat everything from a motor perspective.
Thank you for explaining that. And I want to try to simplify this anymore. So you're going to tell me if this is like too simple, but I'm trying to think of, I just started playing tennis recently. So this kind of reminds me of like how you would improve like your tennis moves. Let's say it's like how you doing a forehand. Have you played tennis before, Amy?
I'm terrible at it.
Okay. It's okay. It took about a year to learn. Like if I'm trying to work on my forehand, just because I go and work on like one of the muscles in my arm, maybe my arm is weak, right? And you do need your arm to make a good forehand. So I work on my muscles, but if I'm not actually working on the movements and the rules to do that forehand, it's never going to get better.
I think it's a great metaphor because like you said, it's so much more than that specific movement. It has to be task specific because you're never going to get your forehand right. You're never going to hit that ball if you don't practice the timing of, okay, when do I need to start moving my arm when the ball comes here in order to hit the ball with the racket, right? That is a task specific movement that you need to practice in order to get good at that. And so speech is the same exact thing. And I would say, because I do hear this a lot, like, well, what about the weakness there? So here's the thing about weakness. If we see muscle weakness, we would not see sound specific errors. If we see weakness, that is called dysarthria. And with dysarthria, we don't just see, oh, they have a trouble with the R sound, right? We see that child or that person has usually other subsystems impaired as well too. So we will see weak articulatory contact across the board, not just on L, right? Not just on T, but we would see it across the board. We would see weak articulatory contact. We would see likely like reduced breath support. We might see differences of resonance. We're going to see vocal loudness issues. So we as SLPs need to be super careful when we say it's a weak tongue. Because if it's weakness, my first question is also, well, have you assessed for weakness? When you did the oral mech exam, did you apply opposing pressure to see if there is indeed weakness? because just because they can't do a sound, do not assume weakness. If there are other sounds, especially that they can produce, where that same movement is necessary, like if you think, oh, they can't say, the L sound, they weak tongue, they can't elevate it. Well, can they do T, D, N? Those are other alveolars where you have to use a similar movement. If that's the case, then it's not weakness. Now, I will say this, though. If you have a child who struggles with L and they say other sounds, T, D, N, L, and that tongue is forward or bladed, and it's like the quality of the production, that tells me that, yeah, you know what? There may likely be an underlying myofunctional impairment because that tongue is just kind of in the wrong place all the time, even for those sounds that perceptually sound okay. So there might be an underlying myofunctional impairment with that particular child because maybe their tongue is just kind of struggling to get in the right spot for other sounds too. So again, nuance, right? So much nuance. But I think what you were kind of talking about with the racket and the tennis, absolutely, I would completely agree. It's a great metaphor. If you want to get good at tennis, you have to practice tennis, right? You can't just stand there and do one of these, practice in front of the mirror. You're never going to get good at tennis.
Yeah, thank you. I was trying to make it like connect to the topic that we're talking about,
Yes.
but such a good point too about it would be sounds across the board if it was a issue with weakness. So
Absolutely. I use that too when I talk about, because I have a whole course on lateral lisp remediation. I hear that too, like, oh, well, they have a weak tongue. They can't get the sides of their tongue up. And my question is, well, if you can do N, T, D, E, if you can do the E sound, like the sides of your tongue are up. It's not about weakness. It's about, this is just a movement you've never done before. Like you learning tennis. I'm terrible at tennis because I've never done I'm not motor impaired. I don't have a motor impairment. I can move my arms. I'm just not good at that task. So I have to do it hundreds and hundreds of times before I get better at it. So I think that's a good way to think about it too. I'm not a motor impaired person. I move just fine. I'm just not good at that specific task. So if I want to get good at it, I have to practice that task.
wow, such a good way to explain it. Why do some kids, this might be like for a whole other presentation, but I'm going to present it anyway. Why do some kids just not naturally learn how to do some of those sounds?
I wish I knew. And I think so many, like, it's one of the most common questions I get from parents, like, why did my child have this speech sound disorder? And in the vast majority of cases, there's nothing we can pinpoint and say, well, you didn't show them how to do, it's not like we have an obvious idea as to why some kids have these, particular speech sound disorders. So it's the hardest thing to answer. And honestly, most of the time they're idiopathic. We just don't know. So sometimes I think there are kids that have underlying myofunctional impairments that, yeah, maybe that is, I would say, I have a hard time saying the word cause, but contributing to speech sound errors, sure, absolutely. Especially those older kids who are like, still struggling with S, that lisp or that R sound. Could their orofacial myofunctional impairment be contributing to their lack of progress? Absolutely. In fact, when I see that, those are the kids that I encourage, like, I'm going to still work on the speech because that's how we're going to improve speech. But I think you should consider seeing an orofacial myologist to kind of work on these other underlying functional issues for getting your tongue in the right spot at rest, looking to see, are there potentially underlying, upper airway issues that should be resolved so that you can more comfortably rest your tongue in your palate. So there's a lot of things that those orofacial myologists can help us with, especially for those kids where it could potentially be contributing to their lack of progress in speech therapy. But to have a causal relationship, I just don't know if we know, honestly, as a profession. I certainly don't.
Sure. Yeah, that makes sense. So we've talked about how there is no clear connection between OMDs causing speech sound disorders and that the research kind of shows that using OMT therapy, whether in conjunction with articulation therapy or standalone, it has not been shown to be effective. So what approaches are evidence-based to treat it?
Yeah. I think, first of all, before we as SLPs think through what approach am I going to use, we have to differentially diagnose. Like, what is going on with this child? Is it primarily, are they showing these phonological impairments, then, consider if it's a mild impairment, minimal pairs. If they have a phoneme collapse, multiple appositions. If they're significantly impaired and they're just missing a lot of sounds in their inventory because they have a lot of omissions and substitutions, consider complexity approach or the cycles approach, especially for our kids who are impaired, that are significantly impaired. Consider incorporating phonemic phonological awareness. That will help improve speech as well too. But if it's more of a like an articulation distortion, like they're distorting this sound, that's a motor-based impairment. So using a motor-based intervention that's going to incorporate motor learning principles to help them learn precise production, and then, increase complexity of that production, increase the variability of producing that. So like speech motor chaining is a fantastic evidence-based intervention for kids with articulation errors. There's the traditional Van Riper style, which, can be, an appropriate approach for an articulation error that's motor-based, but an articulation type of intervention is not going to be effective for for phonological deficit, because it only addresses production. It doesn't address, do you understand the rules? Right. So I have this example for like, I had a parent who follows me and messaged me and said, there's something wrong with my son because I see you talk about the snake sound and he can do it. And so she's thinking, great, he's got the snake sound. He can say S. And then she asked him to say the word snow. And he said, no, because it's not a motoric issue with him. He can motorically produce S, right? He just doesn't know the phonological rule that the word snow has to have an S on it to change the meaning from no to snow. So you have to use an intervention that's going to be, going to address that. So it's about understanding what is the underlying deficit, what's the most appropriate intervention for that deficit. And then you have your motor speech kids, right, with apraxia or dysarthria. And those are, we're working on consistency and accuracy of movement. So like with apraxia, DTTC or rest or potentially prompt, right? Like those are all going to be more appropriate for those types of deficits.
So many different options. I know you have other courses specific to this topic. Can you share a little bit about those in case anybody wants to learn more?
Yeah, my newest webinar, I just had it, I recorded it a couple weeks ago. It's 2 hours. It's available on my website called Cracking the Code, Differential Diagnosis of Speech Sound Disorders. So if you feel like you're struggling with that, because I feel like most of the time, if we're not making progress, it's because we have not chosen the right approach. And we're using that traditional articulation approach that just is not efficient nor very effective, honestly, for most of our kids with speech sound disorders. And so that can be really helpful. I have courses on the complexity approach and cycles approach, and I have courses on remediating R sound and lateral lists. So I have a whole host of courses that you can find on my website, grahamspeechtherapy.com.
Perfect. And we do include the link at the end too. This is just like a thoughtful question. Do you feel like maybe sometimes clinicians move or revert to like OMT or like the traditional artic therapy because it's more accessible and easier to implement? It seems like when you're giving all of those other options, like you really have to, like you were saying, what is it? Scope of competence. Like you really do have to have that scope of competence in all of those different approaches, I feel like.
Right. It's so true. And so that's kind of my goal, is to make those very digestible and make them easier to understand. Like the complexity approach, I feel like if you work with kids with any kind of phonological impairments, you need to understand the complexity approach because it will make your life easier. You'll get kids off your caseload faster. So will it take some work up front to kind of understand the concept? Absolutely. But once you do, I have people report to me like, oh my gosh, I've had kids on my caseload for 5 years working on all these sounds that they're struggling with. I started using complexity. Now I'm getting kids off my caseload before they get to kindergarten because it remediates those particular deficits so much faster. But I do think, right, like there's, especially when you're a generalist SLP, right? And you're seeing all the things, not just SSDs, it's hard to keep up with, oh my gosh, I have to, like, this particular kid needs this intervention. Like, it's just a lot. And so I think we always revert to that articulation type of approach. And then I also think too, we have the tendency to blame underlying structural or functional issues if it's something that we're just struggling with to treat, right? Maybe we just don't have the time to really do that professional development to learn how to remediate that. And so if you see like, well, they have an open bite and, their tongue is always out of their mouth. So that's why I can't fix their S sound. Well, maybe it's just because we're not specifically treating the type of speech sound disorder that they have. Now, maybe there are orofacial myofunctional impairments that need to also be addressed to help that child improve. But yeah, I think sometimes it's easy to blame something that we don't have to treat. Like if you're not an orofacial myologist, you're like, I can't treat it. And that's why they have that speech error. That's not always necessarily the case. And I would say most of the time that's not the case. We can still treat it effectively. But yeah, I think too, I mean, my heart goes out to SLPs who are in the schools. I was in the schools for a lot of years and man, I just always didn't have the energy to like really dig in and spend the time that I knew was probably necessary to learn an approach that's going to be more effective for that child. So my encouragement to the SLP who feels that way is pick one. Just maybe pick one new approach for this next year. Give it a go for one kid. Do a case study on one kid and just use this new intervention that, like, let's say the complexity approach for a severely phonologically impaired kid, and use that approach to just see, okay, is this really going to work? Is this kid really going to get better faster than if I use a traditional, hierarchy of articulation? I'd bet you serious money that it will. So that would be my encouragement. Just like learn one new approach and then, sit with it for a while. Just get really comfortable with it before you try to learn something else for another child.
I love that suggestion. You should do a challenge for 2026 with your
I
following.
love it. It's a good idea.
But no, you know what? I also like empathize with SLPs, especially school-based SLPs, because this is probably the type of student they're going to have most commonly on their caseload, besides like language disorders, maybe.
Right.
But you really can't have like generalist knowledge in this if you want to get these kids like off your caseload. You have to be able to, like you said, differentially diagnose, right?
It's so true. And honestly, I know it seems daunting, but in the long run, your caseload will thank you. Because, if my goal is always, I want to get kids off my caseload, especially in speech sound disorders. Like there's other issues where, kids are going to need you for a while. That is not the case for SSDs. We can get these kids off our caseload so much faster. My goal is to not ever have to see a kid over 8 for particular sounds, right? Like me, if they come to me after that fact, sure, we can absolutely remediate it. But like, let's get these kids off our caseloads faster so that your life is easier, honestly. And really, like I said, I know I'm harping on the complexity approach, but it simplifies what you're doing because you're only going to target 1 or 2 complex clusters likely. But if you choose the right ones and that's all you do, you're just focusing on some words with that cluster in it, those kids are going to improve so much faster if their impairment is phonological in nature and they just are missing a lot of sounds in their inventory. So yeah, I think that would be my encouragement, is just to, take some time to learn it. But then in the long run, once you get comfortable with an approach like that, maybe it's complexity, maybe it's another one, it's going to be much more easier to implement with other kids.
Yeah, it sounds like it. And I can tell you that I have not touched the complexity approach in probably 10 years. So
Well, and it seems daunting. Like if you've read some of the articles, you're like, whoa, I'm going to need to read that 4 more times. And that's why my whole purpose of professional development is to make really complex topics simple, like to make them digestible, to make you feel like, oh, I can do that. Okay, I got it. I think I understand the concept now. Because like I said, we're SLPs, our scope of practice is crazy. And I can't spend, 15 hours a week learning a new, something new every week. It's just going to be way too daunting.
Absolutely. And you do such a good job at making things digestible. So
Thanks. Appreciate that.
So here's your website. And I think all of your resources are housed here. Anything else you want to point them to? I have your email and website on the next page too.
Yeah, I try to stay pretty active on Instagram. So I try to post like therapy clips. I know it's, I started doing that a few years ago just because I knew when I was a newer therapist or a seasoned clinician, but wanting to learn a new approach or a new strategy, it's one thing for somebody to tell you about it or to read it in a book. But when you see somebody put it to action, what it can look like in real life, I found that helpful. And so I try to post a lot of therapy clips and just helpful tips weekly if I have time. But you can follow me at Graham Speech Therapy on Instagram. I post a little on Facebook, but mostly Instagram.
Yeah, definitely check her out there if you're not already. It's amazing to see like what you're actually doing. And then you do a lot of Q&As too, which is really helpful.
Yeah.
And with your beautiful Colorado background.
I try to get that in there when I can. It's so pretty here.
This is the article that we talked about, that systematic review. It is open access, like I mentioned. It is a systematic review, so we would consider the strength of it to be pretty high. So I would definitely recommend checking that out when you get the chance. But Amy, this is like always a pleasure, whether getting to see you at ASHA or getting to speak with you on the podcast. So thank you so much.
Thanks, Vanita. It's been great. I love talking about this stuff.
Hello, hello.
How are you?
Good. Thanks for joining me.
Absolutely.
We had a
dark in my background.
That's okay. You're about 2 hours behind me, I think. So you're probably, what is it, like 7 o'clock now?
Yeah, just almost 7.
Oh, and you are in the process of moving. So thank you for making time for us tonight.
Yeah. Thank you. So if I'm not super sharp with the questions, you'll know why. It's the packing and the stress and all of it.
Well, we'll make it short and sweet. We had a couple of questions come through via newsletter or in response to the newsletter, and then a couple in the chat as well. So one of the first questions that was asked was, when should an SLP consider referring a child with an SSD for an orofacial myofunctional evaluation?
Well, I think you have to think through first of all, your assessment. So that's why when I talk about this in my courses, I go over 3 things specifically that are going to be super helpful for that. One, the case history. And I have my own case history form where I ask parents in parent-friendly language questions like, are there issues with upper airway? Are there noxious habits? How is sleep? How is feeding? Are they messy eaters? Do they have sensory issues? Like all of these kinds of questions can kind of help you understand, oh, maybe there is something going on there functionally, like that's impacting this child's life, not just speech, but maybe there's some other issues. And then secondly, doing a really thorough oral facial exam, oral mech exam. So you're looking at structure, obviously, like you're looking at that palate, you're looking at dentition, malocclusions, you're looking for those red flags of a potential myofunctional impairment, but also, range of movement of the tongue, those kinds of things. And so that paired with, when I'm because, we're talking speech sound disorders here, when I look at like the Goldman-Fristow or whatever articulation assessment you're doing, look at the quality of sound production, not just, were they accurate, yes or no? Because for example, like I will see, if you think of your frontal lispers, those interdental lisps where the tongue is kind of out through the teeth, I often see those kids who also have a co-occurring myofunctional impairment also tend to produce other sounds interdentally as well too, or maybe bladed, where it's not like this crisp T and D, maybe it's T, D, like the tongue, like you can kind of see visually the tongue either pushing against the front teeth or even coming through the teeth. Or I've even heard like T, D, like it almost is like they're using the top of their tongue at the palate to make those sounds too. So I look for the quality of the speech production. So when I see a combination of those types of things, I talk to families about, so here's what I don't address. And I talk about, I don't address myofunctional impairments. I don't address, if there's some upper airway issues that you potentially need to look into. We talk about, basically, I like to refer to an orofacial myologist when I find evidence of an orofacial myofunctional deficit that the parent or the family is reporting that is impacting the child. So that doesn't always necessarily mean it's related to speech. They might be like, yeah, he snores at night. Maybe I'm seeing phonological errors, but the kid is reporting like all of these issues with like upper airway and, swallowing. Like, well, yeah, maybe get a consult with an orofacial myofunctional therapist and consider seeing an allergist or an ENT to kind of see why are there some upper airway issues. So it's not a simple answer. It's not like if I see these 3 things, I always refer. I look at, okay, is it impacting the child, in other aspects of their life? Are parents reporting to me that that's impacting them? Is dentition, something that is a big concern because of maybe some habits then, there's a variety of professionals that could be, great referral sources, or great, to refer these kids to. And it just kind of depends on how they present, which, like I said, I have that oral facial exam course. We talk all about that. Like, what are you seeing? And we also talk about that in the differential diagnosis course that I did, where what are you seeing? What potentially should you consider as far as referrals?
Okay, awesome. Thank you for sharing that. And that makes a lot of sense. And I think it answered another one of the questions that was asked too about the role of orthodontist and dental professionals. So I'll go to the next question, which was, how do you approach therapy with a child who has a persistent lisp?
Oof. It depends on the child. Again, so much nuance. There's no easy answer. That's why we're clinicians, not technicians, right? Like there's no, here's what you do with all your lispers, because I have had interdental lispers who have zero myofunctional impairment. It's just been this habituated error that has persisted, and there is no indication or evidence that they have an underlying myofunctional impairment. So, I'm going to just treat the speech error. However, with kids who have that myofunctional impairment, I'm going to pay careful attention to where is your tongue always, and where is your tongue for other alveolars. Like whenever I have an interdental lisper, that FMV sound, the tongue is out of the mouth like this, then I'm looking for other sounds. So, however, I will say both kids, since I'm addressing, like we talked about earlier, during the actual interview, like we're looking at, okay, where does that tongue need to be? And that's what we're going to train that tongue to do. Regardless of, are there myofunctional impairments? Are there no myofunctional impairments? We need to train the tongue where to go. So now I might start with a strategy like phonetic shaping, where I start with the T sound. Like if you can say the T with the tongue at the alveolar ridge, and it's crisp and it's clear, and there's no, movement of the jaw, like you can in a stable, functional way, produce a crisp T, then you can train that person to hold out the T and create an S. So, but I'll do that with either person. Now it might be more challenging for this child. I might have to teach them where T is. If that person with the myo impairment and the interdentalized alveolars, like we may have to spend more time on, let's learn where the T sound needs to be. And that person may also be getting like myotherapy, and at the same time where they're learning, okay, where do you keep your tongue at rest? Where do you keep your tongue at swallowing? So that can kind of work together. But for both, that's kind of what I do. I love phonetic shaping, and phonetic shaping starting from a sound that is similar in placement to the sound I'm going to teach, but that is produced correctly. So that's why I love T. Very frequently I use T in order to work on S specifically, but I love phonetic shaping for that reason.
Yeah, I've used that one too, and I do like that one as well. Another question said, have you ever experienced a client with like a very enlarged tongue considering their oral cavity? And like, what do you do in that case?
Yeah, I mean, that can often also be associated with, syndromes and, genetic conditions. But I had not a few years ago, I had a teenager who had no evidence of any underlying, comorbidities or, no medical diagnosis. And to me, just to my eyes that has seen many tongues and mouths, her tongue looked very large in relationship to her oral cavity. And her oral, like she did not even have a high narrow palate. Like it looked like a very typical palate to me. So I was like, wow, okay, there's some difference in anatomy here. So what we did is I thought I just have to teach this person how to compensate for that difference in anatomy to make a crisp S. And so part of it was like really training, like, okay, I know you're not gonna be able to get the sides of your tongue inside. They like literally the sides of her tongue were outside of her mold because she had a large tongue. So we focused on what can you do to make the S just be crisp and come down the center, but keeping the tongue tipped back. And so we worked really hard on specific movements that would help her do that. So I feel like there's no easy answer, and you are going to see, some differences in anatomy. It doesn't mean you can't do therapy. Now, it might mean some things might be challenging. It might mean that you're going to have to sometimes be okay with that's good enough. just to make something maybe a little less distorted for particular sounds. But yeah, that's what we did in that case.
Okay, that's helpful. And I've seen that like as well without any like genetic syndromes. And it was so
Yeah,
like fascinating. So,
it
but
is.
it just reiterates the point that you talked about in the entire course, which is you're, working on like the function of the oral motor structures, but you're doing it in regards to that speech sound that you're working on.
Right. Yeah,
Yeah.
like we talked about, I was just kind of re-listening to it a little bit, and like we got to be task specific
Yeah.
with what we're doing. If you're trying to, remediate this sound, think to yourself about, go back to that anatomy class, go back to your phonetics class. What are the placement, where precisely do the articulators need to be, right? Where are the points of contact, and then teach that. And that's where we kind of dig into our bag of tricks for those multisensory cues, like metaphor cues, tactile cues, visual cues, verbal cues, all that fun stuff that they don't teach you about in grad school, but that you learn through years of practice, and hopefully if you have good mentors.
Yeah, absolutely. Well, and isn't that what like Bjorm speech products are based on, is like that using metaphors?
Yes.
Okay.
In fact, that's a big reason why I love using those specific cues, the Bjorm speech sound cues, for tricky sounds, because like, especially like vowels, how do you teach a kid to say eh?
Mm-hmm.
Right? Do you say, okay, now I want you to close your jaw a little bit, pull your tongue back, like that? What?
Yeah.
How are you going to teach that sound? Or if you get a metaphor cue, I think the metaphor cue is like a sneaker with some gum stuck on it and lifting up. And so when you look at it, you're like, eh, like you're going to say ick, right? So it's
Yeah.
like, it's just really intuitive. I love metaphor cues. I love sound effect cues, onomatopoeia. Like I've got kids that can't say, especially for like lispers and lateral lispers who struggle with CH. I will use the metaphor cue of a spray bottle just to sometimes can elicit that sound just a little bit easier than telling them, okay, where do you put your tongue? Right.
Mhm.
So there's, I have a lot of different steps to get to that point, but those metaphor cues can be super helpful.
Wait, what are you doing with the spray bottle? Can you-
So do you want me to explain it?
just briefly, like,
Yeah. Okay. So first of all, I've had some kids who can't get CH at all. Like they're doing this lateral lisp.
Yeah.
And so I'll tell them, like, this cognitive reframing piece that I talk a lot about is, I don't want you to try to fix your CH sound, because that's a habit. When your brain thinks CH, your tongue goes, you do that lateral lisp. So what I'll tell them, T is super related to CH. I want you to do your T sound. If they can do a really good T sound, and if you can do the T sound, again, phonetic shaping, super similar in placement. I'm only going to change one thing about it. I will say, I want you to do the T sound, but push your lips out. And so what that does, it sounds really close to like a spray bottle sound. So,
okay.
but we're thinking about it like a different thing. It's not your CH sound. I'm not teaching you how to like move your tongue differently, because changing a habit is so much more difficult than to create a new one. And so we're creating a new motor plan. We're creating a new habit. And so that's kind of my metaphor cue for the new CH sound that we shape from T.
Love that. Thanks for sharing that.
Yeah.
I don't know why for a second I thought you were like literally spraying a spray bottle where the
Gotcha.
goes, but
Yeah,
so I'm glad
listen,
you elaborated on that.
sometimes I will get a spray bottle out just to,
I imagine.
make it a little bit real. I know. Like, let's get I've gotten like little bugs out, and like, get your pretend bug spray. Let's spray the bugs.
There you go. I'm sure you get very creative. Well, Amy, thank you so much. That's all the questions that we have for tonight. This will be on YouTube and available for people to watch the playback recording on both YouTube and our platform, as well as the podcast. But I really, really appreciate it. And I'm sure if anybody has questions, they know where to find you, and probably love seeing you answer the questions live on Instagram and in your reels and stories. So thank you for your time. Good luck with the move. And
Thanks.
look forward to speaking with you again, seeing you soon.
Good to see you, Vanita. Bye-bye.
All right, bye.